You know, the first treatments were not even 28 days, they were 21 days. And then they became 28 days. Then we heard it was a 30-day program. And people said, wow, that's a long time to be in the hospital. My name is Jerry Mcdonald. And my beginning experiences with both treatment and recovery began in 1974 as a result of my own treatment.
For over 35 years, Jerry Mcdonald has worked on the front lines and also behind the scenes in the field of recovery. Jerry is the Vice President for Operations and Strategic Planning for Beacon House in Pacific Grove, California. He's the founder and CEO of Mandem Recovery in Cathedral City, California, and was outreach manager and consultant at the Betty Ford Center in Rancho Mirage, California, a part of the Hazleton Betty Ford Foundation.
I became so interested and enthused about my own recovery and all of the information that I had been given about the illness of alcoholism that it piqued my curiosity to the point that I returned to school because I would like to find out more about the treatment of addiction as we know it today, alcoholism as we called it then and today. And so I went back to school. I do have a Bachelor of Arts out of Youngstown State in Youngstown, Ohio, and my basic background was in health and physical education. I was a YMCA director before I became involved in the treatment industry. And as a result, I stayed in that business about another year and a half of my recovery. And because I was so stimulated by what I was learning and what I was experiencing, I returned to school at Loyola Marymount University in Los Angeles to study in what was called at that time, and this is 1974, 75, the schools and universities were just beginning to offer some curriculum about addiction, and the particular certificate that was available at that time was called an Alcoholism Studies Certificate. It was a 2-year program, which as a part of the experience, an internship was a part of the studies at the conclusion of the 2-year period, or 24 credit hours for what was called, again, Alcoholism Studies Certificate. And as a part of that experience, I was asked to do an internship, and I inquired about that internship with a person working at what was called the care unit in those days. It was one of the first corporations to treat alcoholism in hospital settings. And there was a person working at that particular facility in Orange, California, was the home base for comprehensive care. It was a lady by the name of Joan McCrae. Now, Joan McCrae moved from the care unit programs to become an employee assistance program coordinator for Hughes Aircraft in Los Angeles. And I went to see Joan while she was working at comprehensive care. And she said, there's a hospital very close to where you live. I was living in San Pedro, California at the time, called San Pedro Peninsula Hospital. And a friend of mine, Dr. William Rader, has just placed a program in that hospital. And perhaps they would be open to you doing an internship closer to home. Because at that time, I was also doing some volleyball camps at Chapman College in Orange, and that's how I got over to see Joan McCrae at Orange at the comprehensive care facility. So lo and behold, I did begin an internship at San Pedro Peninsula Hospital under the directorship of Dr. William Rader, a renowned psychiatrist from Beverly Hills, who had been the second medical director of the United States Navy program in Long Beach. Now, that's a significant piece of information because the very first medical director of the program at Long Beach was a gentleman by the name of Captain Joseph Zuska. Now, Captain Zuska put together such a fine program at the Navy in Long Beach that it really became the go-to program for all of the armed forces and all government employees, especially employees of the federal government that were working in the Washington, D.C. area. And that is, by the way, how Mrs. Ford got the treatment in Long Beach. Captain Joseph Zuska, upon his retirement, passed the torch to Dr. William Rader. Dr. Zuska then moved to, again, what was the fledgling beginning of treatment in hospital-based programs, to the hospital in Orange, California, called St. Joseph's Hospital. And he began the first hospital-based program there at St. Joseph's Hospital with another very familiar name in the industry, Dr. Max Schneider. Now, Dr. Max Schneider wrote a lot of material and was very instrumental in looking at nicotine addiction and to treat nicotine addiction along with the addiction to beverage alcohol or other mood-changing chemicals. So it really became one of the first hospital-based programs that was a non-smoking program. And by the way, Captain Zuska had that experience also in the Navy. That was a non-smoking program. And of course, over the years, we've had that continuous discussion about when is it appropriate to add other addictions to the treatment of what might be perhaps diagnosed as a primary addiction. So Dr. William Rader was the one who I was referred to by Joan McCrae in a little small community hospital in the wonderful place called San Pedro Peninsula Hospital in San Pedro, California. I began an internship there and was immediately introduced to an incredible staff that Dr. Rader had put together after leaving the Navy program as their second medical director. And he had some wonderful names with him that we would recognize in the field in the years to come. He had Dr. Alan Berger was his family counselor. Dr. Judy Hollis, who was a clinical director at that point at the San Pedro Peninsula Hospital, and she later became director of her own treatment of eating disorders, and especially compulsive overeating in the community of Manhattan Beach, California. So Judy was there. Dr. Alan Berger was doing his undergraduate work at that time. Judy Hollis had received her MFT and was working on her PhD. And then an interventionist along the way who became very well known in the field, Mr. Ed Storty. Ed Storty was what we called in those days the community coordinator. And the hospital-based programs had a staff position called community coordinator because there was so little known about the illness of alcoholism at that time that the community coordinator would actually go out into the community and do educational presentations at all of the community service organizations and anywhere that we could get the word out about the illness of alcoholism and where they might find some help. And out of that, through Vern Johnson's work at the Johnson Institute, Ed Storty began his career as an interventionist and later left our center and developed a private practice. He's still doing some great work today, working on yet another book. He's actually completed 3 books about the process of intervention. We also at that time had a number of people from the Navy program that Dr. Rader was involved with, and they also came with him to the San Pedro Peninsula Hospital. At that time, about a year or a year and a half after my internship and asked to become a part of the staff at San Pedro Peninsula Hospital, Judy Hollis, along with the encouragement from Dr. Rader, asked if we might consider doing an eating disorder program, inpatient, using a 12-step environment for the treatment of compulsive overeating. And so since I had some, not a lot, but some experience in administration, they asked me if I would direct the first inpatient program treating compulsive overeating in a med-surg licensed bed. And by the way, in those days, in the beginning of the work in hospitals, we were treating addictions in a med-surg licensed bed in the state of California because there were no chemical dependency beds licensed at that time. That came later as Mrs. Ford and her wonderful group, including Dr. Joseph Cruz, put together what's called a Chemical Dependency Recovery Hospital, the acronym being CDRH. And that was the first time that any treatment facility outside of a hospital was asked if they could have a special licensing at the State Department of Health for a chemical dependency treatment bed. And at that time was when, then that's 1982, that in the state of California, finally, we had a licensed bed for the treatment of chemical dependency. Because by this time, alcoholism and drug addiction, which used to be, sounds crazy, but they used to be treated separately, were merged together. And in that experience also came the very first standalone department for alcohol and drug addiction in the state of California. Until that time, it was treated out of the mental health division of the State Department of Health. So we began this venture of treating compulsive overeating in a med-surg licensed bed, as we were doing in alcoholism in those days. And it was an incredible experience, such a great experience that Dr. William Rader then decided that it might be good if we could put together a healthcare foundation for the treatment of eating disorders, which would also then include bulimia and anorexia. And we put together then what was later then to be called the Rader Institute. That was an institute for the treatment of eating disorders. It was an outgrowth of our work at San Pedro Peninsula Hospital in alcoholism and with Dr. Judy Hollis. Although Dr. Hollis went on to do her own treatment regimen and center, we then began to place eating disorder centers around the country under the corporate name of the Rader Institute. That survived for a number of years, maybe 15 as I best recall, and then finally that came to a close, and the Rader Institute is now no longer in existence. In that experience at the Rader Institute, I then moved back to San Pedro Peninsula Hospital, and then at that time I became the director of chemical dependency services at the hospital in San Pedro. Following that experience, I had an opportunity to do some work at Daniel Freeman Marina Hospital, which was just a little 48-bed hospital in the community of Marina del Rey. And we placed an alcoholism treatment center there, replacing a care unit which had been there for a number of years. So we had that experience, and then I moved on to Hoag Hospital in Newport Beach. And at Hoag Hospital in Newport Beach, we're talking now, we're into the 80s. Probably somewhere around 87 or 88, we placed that unit, and it's still in existence today. It's one of the few hospital-based programs that remain in this area of the country. But at one time, I don't want to overemphasize nor underemphasize that the basic treatment centers in that era were coming out of med-surg-based hospitals and had moved out of psychiatry to some degree, although there was still a great cooperation between the chemical dependency treatment centers and the psychiatric centers, not only in the same hospitals but in the region. I say that as a point of information because my treatment was in a psychiatric hospital, and I have some history in my family of psychiatric treatment for my father's alcoholism. So I'm very familiar with what happened in those days for the treatment of alcoholism, and it was basically electric shock therapy with very little follow-up of counseling and certainly no work with the family. So what evolved out of San Pedro, which I think is its greatest contribution to the field today, was the experience of including family as a part, not a part of, but actually we would say a family systems approach to the treatment of alcoholism in those days. And the model program, which evolved at San Pedro, which remains for me to be the model program, if we could ever repeat it today, was that the patient would come to treatment, and immediately upon the patient coming to treatment, we would have the family come on Monday, Wednesday, and Friday evenings for family. At the same time, the person was in inpatient care. And on that Monday, Wednesday, and Friday, we would start at 5:30. 5:30 to 6:30 were groups, and we had family groups without the children. And then we had an education session for the family and all of the patients that we had transferred to outpatient. We didn't discharge a patient from inpatient to outpatient, but we rather transferred them from inpatient to outpatient. And from the time that they transferred to outpatient, we did another 12 weeks of Monday, Wednesday, and Friday evenings for family treatment. In that family treatment, the last group of the night, which was 8:30 to 9:45, I remember it's the time specifically, we would do family groups. And on Monday, Wednesday, and Friday, we included the children, any of the children from 7 to 12 years of age. And on Friday nights, there were no children in treatment, and then we had the adults only. So it was probably the most intense and complete family systems approach that I had experienced to that time or ever since. So I always want to mention that when I'm talking about my experience in the field of treating addiction, and especially how important it is to treat the family. I had an opportunity to go out of state and put in an eating disorder program at Tucson General Hospital. And along with the eating disorder program, already in place were an adolescent and an adult treatment program. So we sort of administered all three and had an incredible library and bookstore all about the illnesses of addiction. That was an incredible experience until I got a call for yet another assignment. And when I tell you about this, how could I ever pass this up? The same person who was with Captain Joseph Zuska, who went to the hospital with him in Orange, after that assignment was asked to come to Scripps Hospital in La Jolla, California, and place an alcoholism or a chemical dependency treatment program at the hospital at Scripps. And his medical director was a gentleman by the name of Ron Mineo. And they put together an incredibly successful treatment program. They then not only did a great job in putting that treatment center together, the Betty Ford Center had now been in operation for a few years, and they modeled their treatment center after the Betty Ford Center. And it was called the Mcdonald Center. And they had an adolescent division and an adult division. It was a very successful program. Well, later on, Len Balzer, who had been with the Navy in the beginning, with Dr. Zuska in Orange and with Dr. Mineo at Scripps Hospital, was asked to come to Monterey, California, on the beautiful Monterey Peninsula, to a hospital called the Community Hospital of the Monterey Peninsula. And it had an adult program in existence. And Len was now charged with the responsibility of continuing that adult program, which, by the way, was a comprehensive care corporation program care unit. And he then began to do that. And in the course of that experience, he became friends with the mayor of Carmel, Clint Eastwood. And in talking about the need of not only adults but young people to have some help with treatment, Clint Eastwood donated the space and time to develop the Clint Eastwood Youth Program at the same facility that an adult program was being conducted on yet another floor of that particular building. And so I got a call in Tucson if I would be interested in coming to Monterey to help Len put together the Clint Eastwood Youth Program. I did that. I left Tucson, went to Monterey, and was there for 7 years. And in those experiences, we were able to put together this adolescent unit and now had a beautiful hospital in downtown Monterey, which was, by the way, the original hospital for the city of Monterey, and it was called Eschaton Hospital. And the community hospital of the Monterey Peninsula, which started in Carmel, California, had moved a little bit of a distance towards Pacific Grove and Pebble Beach, and now had a beautiful hospital in the forests in the Pacific Grove area. So we were able to continue a program there for some time to come, until what happened with most hospitals, including the particular one that I had the privilege of working at in Monterey, was impacted by a new phenomena in third-party reimbursement called managed care. And when managed care presented itself, stays were so shortened that it didn't make any sense to continue. And so most hospitals across the country, but certainly in the state of California, began to empty out their chemical dependency treatment centers because there just wasn't enough reimbursement from third-party insurers. So this was probably 1980 to 1990 was the run of hospital-based programs across the country. And then after that, most of the treatment ended up in residential treatment centers, or now the newest phenomena over the past decade has been to outpatient treatment, and then to what we call partial hospitalization. PHP is the acronym, where a patient comes for day treatment all day and then may go to a sober living at night and then come back again the next day for their treatment. So in the evolution of the industry, what we're really experiencing is less and less time to be able to treat the illness, which we minimally have always said would probably best be suited for a minimum of 90 days of treatment, which now had become practically impossible under the third-party reimbursement provisions. And then it became only available to people who could afford it as far as the length of stay was concerned. So we're still patching to this day and getting as much treatment for the patients and their families as we possibly can, but it remains a number one challenge of the industry today, is to be able to have enough time to treat the patient and the families. How can we put together enough time with the patients and families to do an effective job of treating the illness of addiction? The difficulty becomes, as we have experienced over the years, again and again and again, the response to the question of how effective is the treatment? What is your success rate? How do you measure success? And of course, it depends upon what your philosophy is and what your model of treatment is about the application of the treatment for the patient and family. For example, when I began my experience, the objective of all treatment that I remember with any sense of good recollection was that the object was always abstinence, and the object was always total abstinence. So that the idea is that once you medically or socially detoxify the patient, then the goal was abstinence, and to stay in abstinence in the beginning and the continuation of recovery without the use of a mood-changing chemical. Now, what's happening today, and this is a whole other topic that we could talk about sometime, is the influence of the third-party reimbursers with the treatment of the illness. For example, there's been some minimal work done on what professionals would consider the core elements of treatment. And so there's some agreement in that, what that is all about. What do you need to have included in the treatment protocol for your center that would be universal in needs of treating chemically dependent people? Those elements now have been accentuated and really embedded in the third-party reimbursement industry, insurance reimbursement, so that you must demonstrate now that you have the core elements of treatment in your treatment center, or you may not be reimbursed for your work. That's sort of interesting. The illness has become so complex in the assessment and evaluation of a patient. We may have alcoholism and depression. We may have alcoholism and some other illness. So that we're dealing with many more components of addiction than we did in the original work in treating this illness. Even to the point where, especially with the opioid crisis that we're dealing with today, some treatments have included in their treatment a detoxification medication, and the one most commonly talked about is Suboxone, that they titrate the patient off of the opiates with this particular med. And they were fairly successful in the titration until they got near the end, and then it became such a problematic situation for a patient to make the final step away from Suboxone, in this case, that we began to experiment with, well, why don't we just continue the treatment at the lowest level of application of Suboxone possible so that the patient will stay in treatment. And so that became, the acronym for that became medication-assisted treatment. Now, certainly nothing wrong with that. The difficulty became when third-party reimbursers got a hold of that. Now it's become one of the components of, unless you do medication-assisted treatment, we may consider not reimbursing. So now we have some things in the reimbursement side that are medically driven or treatment driven, to the point where we may indeed have patients now that are coming to treatment, being detoxified, placed on mood-changing chemicals to continue on and complete their treatment, or at some time during their treatment make that final step off of the med altogether and give a try at total abstinence. So it's become less and less now the objective of many treatment centers that we do not go for total abstinence unless we're absolutely not confronted with that situation about the patient may need to continue on their treatment with a look at how they perform in the treatment with the continuation of a detox med in this particular case. But it could be any other med. So Here's the problem. If we would be able to have a patient for 90 days, that would be a very realistic objective. The problem is the stays are less and less and less. And what happens is that if we continue along this route, we place more and more responsibility for the patient's recovery on themselves. And the difficulty is placing a patient who is dependent upon mood-changing chemicals to dispense and monitor their own use of the mood-changing chemical, which is one of the reasons they probably came to treatment in the first place, is because that was out of control. So it produces a dilemma. People are adjusting to that the best way they can, and there's still lots of room for discussion in that area, but that seems to be what's happening across the industry today as the patients become more and more complex in their presentation of symptoms and in their diagnostic criteria. And as a result, the industry is faced with a big challenge. How I got to the Betty Ford Center was this managed care piece that we talked about. We eventually had to close both the adult and the adolescent unit at the Community Hospital of the Monterey Peninsula. We're going to circle back now to my old friend Ed Storty. Ed Storty was one of the interventionists on the intervention team for the Betty Ford Center. And he talked to John Schwarzlos, the president, and Mike Netherton, the operations officer, about me being available. So I did get a call to come to the Betty Ford Center, but when I came to the Betty Ford Center, the only opening they had was in the admissions department. So I started all over again at the Betty Ford Center in 1992 as an admissions counselor. And it was an incredibly valuable experience for me to step through all of the chairs that I did at the Betty Ford Center. The biggest change I see from my entry into the field to today is that you have to really go back to when Senator Hughes did the big pitch to Congress and to the world and to the country in particular about his own alcoholism and how we must do something to help the alcoholic. And that's when the insurance companies took on reimbursing for treatment. So really the pivot was Senator Hughes to the hospitals having alcoholism treatment programs, to the building of the Betty Ford Center and the Mcdonald Center at Scripps. You know, the first treatments were not even 28 days, they were 21 days. And then they became 28 days. Then we heard it was a 30-day program. And people said, wow, that's a long time to be in the hospital. And under acute care, that is a long time to be in acute care. So we weren't fast enough in the adjustments in that period of time to keep the time frame long, but the reimbursement and or the cost reasonable. So the biggest difference today from yesterday was the access of treatment, and it was longer. Access of treatment today is still good, but it's very short. And so what happens is that the amount of time that we have, and especially in those days, most treatment centers and hospital-based programs were 12-step driven. So the objective of the hospital programs, if they didn't have longer lengths of stay, was to begin to plug the people into AA in those days because we were treating basically alcoholism. Then later on, of course, AA and NA. And then when we did the eating disorders program, there were no anorexia anonymous programs or bulimic anonymous programs, but there was an Overeaters Anonymous program. So our first experience in eating disorders and emphasizing 12 steps was with OA.